Rose is, of course, one of our nurse managers. Her teamwork and dedication, they always speak for themselves. And Rose is currently mentoring a staff member, SICU staff member, through the San Diego evidence-based practice. So she's very involved with many things. Rose is going to give us our OR resuscitation update. So please welcome Rose.
Thank you very much. I'm just going to go over operating room resuscitations. This is something that's unique to UCSD Medical Center, and for you that have been in trauma, know that we've been doing this since the inception of the trauma center here many, many years ago. It was modeled after the practice at Baltimore, the shock trauma center there, and we're pretty much one of the few places in the country that do it this way. I don't know that any other hospitals, even in California, do OR resusces like we do here. So some of the objectives, we're going to talk about the rationale for OR resusces, what the triage criteria are, who the team members are, what their roles are, some documentation issues, some of the challenges that we face, and then we'll go over a couple scenarios where you can decide what you think it should be an OR resus or not. So why do we do OR resus? Mostly because some critically ill trauma patients require immediate surgical intervention. That's our number one reason. You can have time delays when you move from the resus room to the OR if you get started in one spot. Also, when you do move somebody from the trauma room to the OR, you have to move them from the gurney initially to the trauma bed, and then if you're going to move them again from the trauma bed back to the gurney, then to the OR, then from that gurney onto the OR table, there's a lot of opportunities to lose lines and airways and that sort of thing in a really unstable patient, so not such a good idea. And also a lot of times patients are so unstable that their operation and their resus have to occur simultaneously. So to that end, we have one OR that is available 24 hours a day, every single day, that is set aside just for trauma resus. And if there is any indication that all the ORs are full for whatever reason, there's a trauma in there, all the other ORs are full, then the OR staff, whoever's in charge of the OR that day, the trauma attending, need to get together and figure out whether we're going on trauma bypass or they need to make something else available, who's going to get finished first, make another room designated, so they need to have a powwow about what to do if the ORs are potentially full. And they usually post that on the board right outside the entrance to the OR, right at that little office there. So what are some of the triage criteria for OR resusces? The biggest one is any patient who's in full cardiac arrest. If it's secondary to penetrating trauma, they do not have to have any vital signs. If they're secondary to blunt trauma, they need to have some indication that there was some vital signs witnessed by somebody who knows what a vital sign is. Okay, like if the paramedics get there and they have agonal respirations, or they had, maybe a thready pulse, something like that. If they're blunt trauma, then they can bring them in and make them an OR resus. Otherwise, if it's blunt trauma and there's no sign of life at the scene, then they usually will call them at the scene and avoid bringing in a patient who is clearly already deceased, and we're not going to be able to do anything to help them. People that have bleeding issues because of penetrating trauma, we're much more likely to be able to save them than somebody who's a blunt trauma. Any patient who's hemodynamically unstable and unresponsive to pre-hospital volume administration, that's normally a blood pressure less than 90. The pre-hospital volume administration is a little tricky because usually the run times are so quick, from the time that they get picked up to the time they come in, there's not really time to give them a whole, even 500 cc's. Most of the time they come in with maybe 100 out of the bag in the patient. So if they're hypotensive, whether or not they've got an IV going, then you can use that blood pressure as a criteria to decide. Any penetrating injury to the torso with a blood pressure less than 90, that's sort of the common factor there. Any major external hemorrhage that's uncontrollable by direct pressure or other means. If they can't get a handle on the bleeding, then they probably need to have some sort of operative intervention. And then, of course, if there's any direct airway injury or compromise, that's a little kind of gray area. Some of the it's not specifically in the policy, but I think most of the trauma docs would rather be able to surgically control an airway in the OR instead of in the trauma room. So if there is any, question about that direct airway injury, then most of them like to go to the OR. Another things to consider, if there is an amputation or evisceration without unstable vital signs or uncontrolled hemorrhage, they do not need to go to the OR right away. Of course, they're going to need to go at some point, but they don't need to be resuscitated there. If there's isolated penetrating trauma to the head, generally that's not an OR resus, but there's always, gray areas with that as well. And depending on the report, if it's something that's like self-inflicted. So there's really no possibility of any other injury, because once you sort of shoot yourself in the head, there's really no way that you're going to shoot yourself anyplace else or, other than maybe falling down. So, those ones could be considered isolated. But if it's another source of a gunshot wound to the head from somebody else, there could possibly be other undetected injuries. So that's a possibility. They might be able to qualify for OR resus. If they have penetrating neck trauma and complete airway obstruction, then they do need to go to the OR. And if it's a transfer, we get a lot of patients from the desert get transferred out here. If they meet the other criteria for OR resus, then they do go straight to the OR. Okay, so the important thing is when we get a notification about an OR resus or about any trauma patient is that if you make a decision about the OR resus, then you need to leave it at that, unless there's extenuating circumstances. But decide as early as you possibly can and then try not to change that, because it's hard to get people who have already sort of been heading over to the OR to change and come back to the resus room. Sometimes people don't always get there in time. So we need to report all the known injuries to the OR staff to facilitate the room setup. They need to know what trays to open and what to anticipate the doc's needs will be. So what happens when you get the call? The MICN will relay the pre-hospital information to the trauma resus nurse who picks up the call in the ICU, and then that nurse will determine OR resus status. Now, if the paramedics have told the MICN that it needs to be an OR resus, then and they have the data to support that, what's going on with the patient, then we try not to change that just because it makes it difficult. They're the ones who are actually looking at the patient, and they probably have a good handle on how sick the patient is. Now, if they give you a report of a patient who sounds like they should be in OR resus but they did not mention it, then by all means tell them before you hang up, I'm going to make this an OR resus, so they know what to tell the medics, where to bring the patient when they're coming in. So after you get the call, then the trauma nurse calls the hospital operator who puts out a group page for an OR resus. The MICN is then responsible for notifying the OR to tell them what's coming in, and also going back to the pre-hospital personnel and telling them to bring the patient to the OR instead of the trauma room. Okay, so there's always this question about can you re-triage? At the time of the initial report, you can make the patient an OR resus no matter what the ETA is. Okay, whether it's 2 minutes, they're at the back door, that's a hard one, but you could still do it. 10 minutes, whatever. If you get an updated report, you get the initial report and the patient is going to go to the trauma room, you get an initial report and it sounds like they need to go to the OR, you can re-triage if the updated ETA is greater than 5 minutes. Again, that's trying to get people, back and forth from the OR to the resus room in the appropriate time. I know back in the old days when the trauma room was on the 5th floor, it had to be greater time period from the initial report because the nurses had to travel from the 5th floor down to the 2nd floor to do the OR resusces. So we're down the hall. That's not an issue with the initial call. Okay, so who is going to be there? We have any number of physicians. Depending on days or nights, we get lots more during the days that sort of come and join us. The attending trauma surgeon, the fellow, senior resident, junior residents, medical students, and of course anesthesia reports as well to the OR. Trauma nurses, we have a trauma monitoring nurse, trauma circulating nurse. There's an OR scrub nurse, an OR circulating nurse. And then ancillary staff members, our trauma tech comes over, the OR runner or technician, radiology tech. So about 20, 25 people get notified, and about 15 people show up. So it gets very crowded in there. So it's crowd control. It's a big problem sometimes. Going over who does what in there. The trauma attending physician, they're the ones who are in charge of the overall resuscitation and surgical procedure if they decide they need one. They supervise the fellow and the residents. They stand on the patient's non-sterile side. In the ORs, I'm sure most of you are aware, we have a sterile side of the patient and a non-sterile side. If they end up having to do an operation, there needs to be a sterile side where they can open the trays and do a regular operation in there. In room 11, OR, which is our usual room, the patient's right is the non-sterile side, and the patient's left is the sterile side. Trauma attending assists in airway control if that's needed. Excuse me. And they direct any surgical procedures that need to happen. Trauma resident will stand on the patient's sterile side. They are in charge of IV access and drawing blood. If there's an A-line that needs to be placed on that side, if anesthesia hasn't already done it. Any procedures on the left side of the patient, chest tubes, thoracotomy, DPL, anything like that. Medical student or junior resident, there's usually one on each side of the patient. And they have to know, which guy's sterile and which guy isn't. They help with Foley placement, the rectal exam, blood draws if necessary, and they can also pump in fluid if they are competent to do so. They need a little instruction, but I wouldn't let them use a level 1 because that requires one person only. Trauma monitoring nurse. They're the ones who receive the call from the MICN, places the group page. Then you have to get all dressed up to go to the OR. Lead apron, shoe covers, the yellow gown, the head covers, the mask before you go in. Bring your tetanus and your paperwork. Excuse me. And the trauma nurses will stand on the patient's non-sterile side. They take the initial blood pressure with the cuff and continue until the blood pressure is stable or an art line is placed, and we'll get back to that in a minute. They record the vital signs, any eyes and nose, any sort of documentation, lab results, x-rays, and narrative of the resus. And if there's any need for medications that anesthesia won't be giving, then the trauma monitoring nurse will give that. That's diminished quite a bit. I think in recent years we don't normally give too many medications anymore. And it's very important to continue to call out loud vital signs, fluids, blood administration, so the whole team can hear what's going on. Sometimes that involves, craning your neck around the patient and looking at the monitor once the art line is in and stuff. But the trauma docs do appreciate and need to know that information. And they might ask you to stick around after the resus phase is completed if there's a need for doing a lot of fluid and blood administration. Circulating nurse. She would stand or he stands on the patient's non-sterile side again and assisting with any procedures, DPLs, chest tube setup, IV access. This is nurses responsible for checking and hanging blood products down at the bottom half of the patient. The circulating nurse will operate the level 1 infuser if that's needed, and also works with the trauma technician. Trauma tech will get any necessary equipment that needs to come over from the trauma bay, will assist in setting up for any procedures, labels the blood samples and transports to the lab. Now sometimes the OR technicians will do that, so they need to talk to each other at the beginning and see who's going to handle what. Assist in obtaining blood products. If there needs to be a massive transfusion protocol done, they will get that stuff together. And they assist the OR staff during the resus phase as well. So anesthesia, they're another big part of this that we normally don't see over in the trauma resus room. They help maintain the readiness of the OR. They're supposed to make sure that all the equipment is up and ready to go. They are responsible for airway management, ventilation, and anesthesia. And they're responsible for monitoring vital signs after the initial blood pressure and once the art line is placed. They help with volume management with any lines that are up in the top half of the patient. They help place lines in conjunction with the trauma attending. And they need to also communicate with the team about their management of the patient. If they have any need for hemodynamic support, they try to, or they're supposed to actually discuss it with the trauma attendings before they give any vasoactive drugs. I know you guys have been in OR resuscitators, know that doesn't always happen. But so if there's any wild fluctuations in the blood pressures and stuff, you need to talk to anesthesia and see what they're doing, because sometimes they don't always tell you. They manage the acid-base balance and check ABGs. Again, a lot of times we'll have to request the results for them so you can document. They monitor coagulation status and patient temperature. And they will also notify the trauma docs if they have any sort of undetected head and neck trauma, any depressed skull fractures that they would notice up on their end of the patient. And they can also assist with controlling any bleeding that's going on up there. OR scrub nurse, another person that's quite helpful in there, is on the patient sterile side. They set up to perform open cardiac massage if that's necessary. They are the ones in charge of maintaining sterility in the OR. So if you stray onto the wrong side, they will let you know. They set up whatever sort of appropriate tables are necessary. If they need a chest tray or a belly tray or whatever, they're responsible for that. And they don't assist in the resus phase. They're totally responsible for being maintaining sterility and stuff. So that's pretty much occupies their attention. OR circulating nurse will make sure that our trauma cart is in the right room. They open up all the trays, gowns and gloves, drapes, all that stuff. They handle the patient paperwork. They're the ones over by the phone and the desk over there. And they also help in preparing the paperwork, lab work, emergency blood forms, that sort of thing. They are supposed to keep track of what blood is available and letting the docs know about that. They will make sure that the supplies that everybody needs is there or they can get them. They're also responsible for helping with traffic control. Again, that gets very crowded in there, and try and get people to go wait out in the hallway if they really need to, hang around and see what's going on. They're responsible for disposition of the patient valuables and belongings. This is very important because a lot of times there's an issue about that, and it's wherever the patient is located, whether it's the OR, it's the OR staff that's responsible for doing that. And they also are responsible for making sure they have their consent forms done appropriately. The OR runner, they have another technician there. They help backup support for the OR circulating nurse, going fetching supplies and blood products, and any other duties that they need them to do. So documentation in the OR is a little tricky because there's really not any room to spread out a trifold flow sheet, and things are happening so fast that it's really hard to document. And what most people do, and what seems to have been work for most people, is they just get big strips of 2-inch white adhesive tape and they stick it on their lead apron and start documenting on that, and then transfer it to the flow sheet later on. It's hard to keep track, but you can do it if you keep little notes to yourself about what's going on as you're doing the vital signs, when you do blood draws, when they do any sort of procedures, that kind of thing. So as much as you can possibly get on there to reconstruct later is helpful. And what you want to do is try to tell the story, what happened to the patient and what was the outcome. It's a good idea to save blood and IV fluid bags to count up for a total count at the end. If it's really hard for you to keep track of each one individually. It is. If they're getting massive transfusion protocol, then it's nearly impossible because those things are going up every 2-3 minutes. So if you can just toss them in a corner, count them up later, that is okay as well. And then try to document any important events that are going on. If they're cross-clamping the aorta, you might lose your blood pressure, and then, kind of wondering what happened at that point in time. If you can say, well, this is when they clamped the aorta, it's like, oh, okay, well, that's fine, it's no big deal. But it does help to, again, tell the story of what happened. So some of the challenges that we have with OR resuscitators, one of them is over-triage. The hard part is that we are deciding here in the hospital what to do with the patient, and we're not seeing the patient, obviously, and we're getting it from like 3 people back. So you have to use the information that's made available to you, and you have to decide with that. And it's not always easy. And sometimes, patients come in that are awake and talking to you, and it's like, oh, well, they probably didn't need to come here. But, if you're working off the information that you have, then that's the best decision that you can make. If the pre-hospital people make a decision for an OR resus, then it's very rarely changed. Again, because they're seeing the patient and we're not, and we need to kind of trust their judgment sometimes. Again, it can be difficult. It's probably better to err on the side of caution, having the patient go to the OR rather than having somebody, in full arrest in the resus room. That's not ideal either. It's probably, I would prefer to have a awake and talking patient in the OR than having a, arresting patient in the resus room. If the docs are around and you have a few minutes, you can, and you're not sure, run it by them when you have the MICN on the phone. That's another thing to do, is use your resources that are available if you're having a hard time deciding. Some of the other challenges are discomfort with the OR staff and the trauma staff, because, the trauma nurses, we do trauma resus, we don't do OR procedures, so that's not our environment. And the OR staff does operations and not trauma resusses, so they're in their environment but not doing what they normally do. So, and it's also higher level of patient acuity most of the time, higher level of anxiety amongst all the team members, so it can get a little tense sometimes. They're fairly infrequent still. Last time I looked at the numbers, it was probably about 2 to 3% of all trauma resus admissions, so not a lot. So we do try to do, occasional yearly education of the nursing staff, and hopefully that's going on in the OR with the OR and anesthesia staff as well to keep everybody up to speed. Some of the other challenges that we have are role overlap, and I know anybody who's been in an OR resus knows this goes on, and it's been going on for, 20 years or more, and I don't know if it's going to change. So, we just have to sort of work with it. Between anesthesia and the trauma monitoring nurse, who's going to take the blood pressure? The nurses want to take the blood pressure manually with a cuff at least once or until it's stable, and anesthesia wants to put on that automated blood pressure cuff. So, you get one blood pressure taken and anesthesia rips it off and puts theirs on, and then we take theirs off and put ours back on, and it's sort of a little, battle. So just sometimes if you can get in there earlier and say, hey, I'm the trauma monitoring nurse, and this is how, we need to take the blood pressure. Could you wait a couple minutes until we're set before you put that on? Talking to them, little communication sometimes will help. Sometimes not, but, can't hurt to try. Medications, again, the trauma nurses used to give things like antibiotics and stuff, but I think that is not so much anymore. Anesthesia usually handles that. And again, lab results. The trauma team, the surgeons need to know, what's going on with their labs. Is their base deficit getting worse, better, whatever? And a lot of times that information needs to be requested when the labs come back. So don't forget to recheck on the results after a while if you don't hear from anesthesia. They usually walk in with a little slip in hand, write it on their sheet, and continue. So we need to ask them for that sometimes. Trauma tech and the OR runner sometimes will overlap. Again, decide ahead of time who's going to get the blood, who's going to run the labs, that sort of thing, so that they're not both running over doing one thing when one person could be helping with something else. Trauma circulating nurse and junior docs, who's going to set up for procedures, assisting with procedures, running the level 1. I would say having the docs do the assisting with procedures and having the nurse do running the level 1. That requires somebody to be there on that machine and doing nothing else but that machine. So it's not something that we normally recommend that the physicians do, and certainly not medical students. Okay, so we're going to have a little discussion. You guys can let me know what you think about these scenarios, about whether or not they should be OR resusces or not. Okay, this first one is a 45-year-old male. Gunshot wound to the head, entrance to the occipital area. Also a gunshot wound to the chest and left scapula. Blood pressure is 140/80, heart rate's 86, agonal respirations, and intubated. Yes? No? Would you take him to the OR? No. I would not take him to the OR. He doesn't meet the criteria. His blood pressure is 140. He's intubated. His airway's protected already. So this is not an OR resus patient. He may need to go to the OR because he's got a gunshot wound to his chest. That might need something, but he may just need a chest tube. You don't really know. So this does not meet OR resus criteria. Okay, we have a 40-year-old male who's a motor vehicle crash at 40 miles an hour into the divider. Major front-end damage, head lack, near amputation of the upper extremity, blood pressure 60 over palp, heart rate's 100. Yes. And what's the criteria there? Blood pressure, right. Yes. Thanks, good. Okay. A 15-year-old male has multiple stab wounds to the left chest and the left cheek. Blood pressure is 100 over 60, heart rate 78. Respiratory rate was 60, now it's 42. Decreased breath sounds on the left, no tracheal shift, oriented times 3. Yes, no, no. Yeah, he doesn't technically meet the criteria because his blood pressure is a little high. The heart rate is, it doesn't make a lot of sense because if somebody's hypotensive, you think you'd have a higher heart rate, for compensation. So that may be, not a true blood pressure. But even so, it doesn't meet the criteria, so.
You mean if you saw a little tachycardia with that heart rate, that would make you...
It would be more concerning for somebody who's actually got some fluid loss or blood loss, but a blood pressure of 100 doesn't meet the strict criteria for that. Yeah. Okay, 33-year-old female was ejected from an SUV, decreased LOC, combative, ETOH on board. She's got 2 IVs in, they're wide open. Blood pressure is 88 over 54, heart rate's 140, respiratory rate is 18. Circumferential avulsion to the head, right open humerus, fracture, ETA by air 8 minutes. Yes, definitely. Definitely. Okay, another one, a 24-year-old male, peds versus auto at 35 to 40 miles an hour. Alert and oriented times 2, obvious right knee, left ankle, right forearm fractures, chest and abdominal tenderness, left head lack. Heart rate is 102, respiratory rate is 18, no blood pressure available, ETA is 15 minutes. Sorry? Well, you don't know. That's what you got. Yeah, you could go either way on this one. If you don't have a blood pressure and you think it's because that the patient doesn't have one, you could ask that question. Are you unable to get a blood pressure, or is it too noisy in the rig? You can't hear it, whatever. But if you don't have this, you would be okay going either way with this patient. But you do have a 15-minute ETA. You could ask them to check and then call you back. So they did. And the blood pressure is 102. ETA is now 3 minutes. Would you retriage? If you had made this guy an OR resus? No. Definitely not, because there's only 3 minutes on your updated ETA. That's not enough time to, get the team back to the other area. Okay. We have a code triage. You guys all know what that is? External disaster. Okay, plane crash at Lindbergh Field. 45-year-old female with massive facial trauma, burns to 60% of her body, possible C-spine fracture. Blood pressure is 80 over palp, heart rate's 130, respiratory rate 30, and labored. ETA is 10 minutes. Who said no? Besides Dana. Okay. Why not, Lisa? It's a code triage. We do trauma completely differently if it's a code triage. Okay? Totally differently. So nobody gets to be an OR resus in a code triage. This is just a regular old trauma. There wasn't like 90 other people in the crash or whatever. It's just her. Then she would definitely be, because she meets the criteria. But code triage, all that stuff is done differently. Okay. Male motorcycle accident with the helmet, struck a pole, is combative, questionable LOC, rigid abdomen, right pneumo, right femur fracture, abrasions to the right chest, no lower extremity movement, no vital signs available. Yes? No? You could do this. Yeah. Again, it's another one of those, you don't know. You don't know. Yep. Okay, so you get an update. The heart rate is 150, blood pressure is initially 100 over palp, now no blood pressure, no IVs are in. ETA is 10 minutes. Retriage, would you send this patient to the OR now? Yes. He meets the criteria and you have enough time. So I would definitely have this patient go. Even if they have had no IVs in, they didn't get a fluid bolus, doesn't matter, send him anyway. Okay, 28-year-old male, helmeted passenger motorcycle accident in El Centro. Decreased LOC for 20 minutes, no blood pressure on arrival at El Centro Hospital. Got IVs in, blood pressure got up to 70. They have a widened mediastinum and a hemothorax. Chest tube outputs 2,500 cc's, then blood pressure went to 38. Intubated, paralyzed, on maximum dopamine has received 7 units of Pac cells and 9 liters of crystalloid. Did you make an OR recess? Yes. You can do that. Just because they came from another hospital doesn't negate the criteria. If he meets the criteria, then they can go to the OR. Okay, 50-year-old male, Peds versus Auto at 50 miles an hour. Hit their head and then landed 50 to 60 feet away. Positive LOC, pupils are fixed and dilated, agonal respirations, intubated at the scene. They've got their C-collar, backboard, no IVs, and no vital signs are reported. What do you think? Any thoughts? Think this guy's likely to make it? What's that? Yes. He technically meets the criteria because he did have agonal respirations. He's a blunt trauma, but he had signs of life before, they lost all vitals. So this guy could be an OR recess. Not likely for survival or even doing well at all, but he can definitely meets the criteria for OR recess. Okay, 40-year-old male, gunshot wound to the head with a .44 Magnum, oriented ×3, neurologically intact. Blood pressure is 118/70, heart rate's 110, respiratory rate 30, ETA 10 minutes. No. On any count, he doesn't meet OR recess criteria. Okay, then you got an update. He's no blood pressure, he's pulseless, ETA 6 minutes out. Would you retriage? Yes, you could. Now, if this guy was totally isolated, gunshot to the head, and we knew that it was a self-inflicted wound, then, the docs might say, no, we're not going to do that. But he does otherwise meet the criteria, and you could retriage him to the OR. Because usually, do you guys know what the rationale is between the isolated gunshot wound to the head, why they wouldn't take him to the OR? Yeah, the survivability is virtually nil, and there's not really a whole lot they can do other than preserve the patient for possible organ donation. So that's why they normally don't take them to the OR, because they can do, ventilatory and fluid support in the recess room, because they're not, an operation on a patient with this kind of wound is not going to help them. So that's why they normally.
You wouldn't retriage him to the OR.
What's that?
You wouldn't retriage him to the OR.
You could, but. Well, yeah. I mean, possibly isolated. It didn't say specifically. So there could be the possibility that he had other wounds someplace else. You don't know. So it depends a lot on who the trauma attending is, what their preference is. But you could go either way on this one. But if it is a known self-inflicted isolated gunshot wound to the head, then the likelihood of having them be recessed in the OR versus the trauma room isn't going to make any difference in their outcome. So they usually don't go to the OR. Okay. Anybody have any questions? Yes.
Seems to be ongoing confusion with those darn yellow gowns. Now, you're saying we are wearing them over to the OR now, and I was told no. So,
What?
we were told we weren't supposed to wear the yellow gowns in the hall. You're saying we do put them on.
Oh, well, I think that's an infection control thing, right? But yeah, I think that mostly refers to whether you have a patient in contact oscillation and you wear a gown. Yeah, this is different. Oh, well. So I don't think they have them in the OR, do they? No. So you have to take them from, you could carry it and, put it on when you get there. Yeah. Because they require them. Yeah, I would go ahead and do that because it's a different scenario than what infection control is concerned about. No. Anybody else? Okay, thank you.